NAP3 has been a very successful project. Its primary aim was to establish the instance of permanent harm, which we defined as harm still existing or damage to a patient still existing at 6 months after the neuraxial block. And I think it achieved those goals. Our success, not only of the project team but also of the profession, was to get every hospital in the United Kingdom to contribute to the project. And so we believe that our denominator data are as robust as anybody has ever produced, and we try to validate our numerator data through a number of national databases, and we're unable to do so because the information is not there. I've not heard of any information that invalidates our numerator data, and even if the numerator data were out by a factor of 2, I don't think it would change our conclusions. So I think the study is as robust as is currently available. I think specifically looking at perioperative care and the use of rigid anaesthesia, particularly central neuraxial block, the key points are that NAP3 has probably provided the most robust estimate of the risk of permanent harm. Although the perioperative group, and particularly the epidurals, were overrepresented in terms of complications and permanent harm, even then the risk estimates were lower than have previously been reported. We did certainly find that the patients who suffered the greatest harm, particularly epidural hematomas, spinal ischemia and epidural abscesses, were largely the elderly and infirm patients having major surgery. So paradoxically, you've got the group that are most likely to benefit from central neuraxial block being also the group that is most at risk of complications. Also, if you're comparing between groups, have to think about the consequences of omitting the neuraxial block and also the potential complications of alternative techniques such as PCA. And I think the data for the complications of central neuraxial block now exist after NAP3, but the comparative data for the risk of complications, for instance, with opiate infusions, PCAs, and iron analgesia don't really exist. We would caution against comparing directly individual groups. So, for instance, comparing between the risk of permanent harm after a spinal in the perioperative group compared to the risk of permanent harm after an epidural. And it's likely that the patients having perioperative epidural anaesthesia are both a higher risk group and also having higher risk procedures. Do I use epidurals in patients that I anaesthetize for emergency laparotomies? I do that on a regular basis, and yes, I do use them, and I won't use them in patients who have a raised or abnormal coagulation. I don't use them in patients who have overt sepsis, but I'm happy to use them in patients who may be at some risk of sepsis at some point. I think it's those patients who have the greatest potential to gain from central neuraxial block, while I accept that they are a high-risk population. It's the surveillance of them afterwards that's very important. What we found in NAP3 was that it was delayed diagnosis that led to poor outcomes in the cohort of complications that we saw. So people ignoring motor weakness, particularly ignoring motor weakness that was prolonged, ignoring motor weakness when a thoracic epidural was running, which shouldn't really cause weakness in the legs, and also ignoring unilateral weakness, assuming that that could not be caused by a major space-occupying lesion in the spinal cord. So surveillance, particularly of motor monitoring, motor power is very important in the post-operative period. the other factor in surveillance which I think is important is to keep the epidural running for an appropriate period of time, but not for excessive periods of time. There were cases in NAP3 where the review panel considered that epidural anaesthesia may not have been appropriate, but certainly was continued for prolonged periods of time. For instance, we had patients with minor amputations, with overt sepsis, who kept epidural catheters in for periods well in excess of a week, which we did not consider best practice.